Good afternoon. I'm Pamela Gentry, Deputy Director of the Office of Minority Health for the Centers for Medicare and Medicaid Services. Welcome to this panel discussion, this session on opportunities to reduce inequitable outcomes and improve customer experience. Along with my esteemed panelists, we'll be discussing how administrative burden in the healthcare system impacts patients and the steps we can take to address those barriers. I want to share a little bit about CMS's approach to advancing health equity and access to care. The CMS framework for the health equity was developed for operationalizing health equity across the CMS programs, Medicare, Marketplace, Medicaid, and CHIP. The framework is just that. It's a guide, a tool, and it's evidence-based and informed by decades of research and stakeholder input. It has 5 priority areas that are very intensive. One is to expand data collection, which we all know is important. Number 2 is to access the root cause of disparities and determine policies and programs that lead towards solutions. The third is to build a workforce capacity and competency in the healthcare system. And the fourth is to advance language access, health literacy, and culturally tailored services. And last but not least is to increase all forms of accessibility to coverage and services. Now, that's a very brief overview of all of our efforts to, quote, operationalize the path to health equity, but we can't do it alone. And that's why this is a great forum and a great opportunity today for us to get started with those who can help us and help inform CMS. With that, I'm pleased to introduce our panelists and a reminder that their full profiles for all of the speakers can be found on the website cmsburdenreductionconference.com. Dr. Jeff Salvon Harmon. Dr. Jeff is the Vice President for Safety for the Institution for Healthcare Improvement and is a certified physician executive and certified professional in patient safety. Dr. Salvon Harmon is a recognized subject matter expert in highly reliable patient and workforce safety, human factors and applications to root cause analysis, and system-level management of quality and safety. Our next panelist is Dante Smith. He's a fierce patient advocate, a national lecturer, and a health educator and cultural curator. Dante works as a leading with lived experience technical assistant consultant for NASDAQ and supporting local health departments in increasing hepatitis engagement for populations through a drug user human rights lens, and is a tenant-based rental assistant supervisor for Kansas City's oldest housing organization for people living with HIV, called SAVE Inc. And Dr. Betsy Toole. Dr. Toole is a fellow in health policy with CMS. In that role, she works on policy creation and on projects of health equity in transplantation and surgical interventions for non-traumatic spine disease. Previously, she was a professor and chair in the East Carolina University Health System as chair of surgery and associate professor of surgery and liver transplant director at Duke University, and a professor of surgery and anesthesia and critical care at St. Louis University. Welcome to all of our panelists.
Hello.
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 Our talk today is centered on the patient experience of receiving care and some of the administrative burdens and challenges that can get in the way of that. Jeff, you have extensive background in a variety of environments where I know you've seen some of these challenges firsthand. Would you discuss some of the major burdens that patients can experience and what that can actually mean to their care?
Certainly can, Ms. Gentry. Thanks so much for both the kind introduction and thanks to CMS.
Jeff, can you hear me?
Thanks to CMS for hosting this event and bringing us together to really talk about these critical elements in the care experience and how that relates to both safe and high quality care. The first thing I would say that's of utmost importance is not all patients are the same. And as we talk about equity, we have to remember to differentiate between equity and equality. In equality, we give everybody the same boost or the same support assuming that they have the same needs. Whereas in equity, we're giving them what they need for where they are. We're meeting them where they're at, and we're helping them to get to an identified goal and providing the necessary support or infrastructure that gets them there. Now, along the way, though, what we end up encountering is that our system designs in healthcare end up posing significant challenges and adding barriers to both the quality of the experience and sometimes even just to the point of receiving care. And so we can think of this divided up in system factors, so those factors that are driven by our healthcare system design, and patient factors, those factors that patients bring with them that we have to be sensitive to and be able to tailor the fit based on. So as we first think about system factors, we can think about the course of care, essentially presenting for care, whether in an emergency department at a hospital or in an ambulatory clinic for primary care or specialty care. There's usually this element of registering for care, of having to fill out paperwork, providing insurance information, completing questionnaires about your health status and your current health concerns. And those in and of themselves can pose a significant challenge and administrative burden to patients, because it's not oftentimes meaningful to them. It's not adding a lot of value, particularly when we think about the questionnaires, for example, related to current health status, that end up having all of those questions reiterated multiple times by multiple caregivers, depending on the setting of care, as if the form had never been completed initially. So we're asking patients to jump through a bunch of hoops, jump over a number of obstacles, just in order to be seen for care, when those are not adding a lot of value to their care experience or the quality of their care. Next, we can think about the transfer of information between sites of care. If a patient presents at an ambulatory setting and needs to be evaluated in the emergency department and is transferred from one hospital to another, if those facilities are on different electronic medical records, that disjointed or non-connected experience may mean that their information does not transfer effectively with them. And thus they end up repeating many of the same questions, collections of history, if you will, and even physical examinations, sometimes diagnostic testing for the purpose of completeness or validating the condition or status they're in, coming from the receiving or from the originating facility. We can also think about the EMR beyond just the disconnection, but the preoccupation of practitioners with documentation in the EMR, and how that takes away from the patient experience when the focus is on checking boxes and the focus is on the computer monitor rather than the patient. It's a very unique skill set to be able to still make eye contact and deliver quality care to patients while attending to documentation and not becoming overly preoccupied with it. But it's that system requirement for both capturing the episode of care, for future episodes to be able to look back and manage in the context of that care, but also in terms of coding and billing in the business model of healthcare. So that preoccupation is driven by the system, but it affects the patient experience, as their practitioner may not be seemingly fully engaged in the care being delivered. And then the last system factor I would talk about is the requirements for screenings that we've seen arise over the last decade. And by not having these unified medical records, it wouldn't be unusual for a patient who receives care at multiple different locations within a frame of time to be screened for the exact same conditions, with low likelihood of any change in status from the first time they were screened, because it's obligatory across the board. And that's a safety net practice, understandably, for those patients who may only be seen once in a year, to ensure they're being screened. But for those patients who are being seen monthly or maybe even multiple times within a month for multiple layers of care, they may be screened for the same thing by different offices at every one of those encounters. And that begins to then create a sense of not being listened to or heard, or that their information is not meaningful enough to convey with them. And they may begin to disengage from the meaning of those screenings and the value they potentially bring. Now, as we think about patient factors, we can think about the initial ability really to understand and communicate in a healthcare context. We use a lot of jargon in healthcare, lots of Greek and Latin terminology, and lots of procedural names, and lots of biochemistry terms for lab tests and what have you. And that jargon oftentimes gets in the way when we can't meet the patient where they're at, having an understanding of what their level of healthcare literacy is. And we're steeped in how we communicate with each other professionally using all of that jargon. And patients oftentimes, in my experience, have been reluctant to raise a hand and say, I'm sorry, I didn't understand, because nobody wants to feel foolish or uneducated. We can think about language and cultural barriers then as we begin to work out from health literacy and the cultural context of the individual in what we call the biopsychosocial model of health and healthcare, not just the biologic model. So understanding the culture that they come from, as well as the language barriers that may result from that, and whether we're making effective use of interpreter services for those encounters in real time. We can also think about their familiarity with the health system and how the health system operates, and when there are differences from one health system to another versus those consistent factors in healthcare. But the frequency with which they engage in healthcare will be a key driver in their understanding of how to navigate within the system. And for many patients, it's entirely foreign. Some years back, I was charged with creating a patient-centered medical home model for the organization that I was working with. And in doing that work, I realized that if care is not patient-centered, that makes it practitioner-centered or system-centered. And I really had to step back and think that while we might want patients to all be stepping up and taking this very active role in their healthcare, we have to understand that they aren't employed within these systems. They don't grow up in these systems necessarily, and may not have the same understanding that we as workers within the healthcare workforce have about how to navigate and how to receive the care services that they're needing and looking for. And so it really does fall on us to help them navigate through the system so that they have both a high quality experience and they're able to follow through on the plans that we're trying to put in place for the care needs that we've identified. And that applies to referrals as well. When it's the lab down the hall, when it's the radiology department or organization down the street or at the hospital, all of that requires some assistance in navigating that we sometimes presume that individuals will have just by us giving them an address and saying, you need to go here at this date and time. Have we factored in their availability? Are they working 2 or 3 jobs? Or are they 8 to 5 workers like we presume because that's how we work? Do they have transportation ease? Do they have their own vehicle? Do they rely on others for transportation? Are they using public transportation? We've seen some assistance with coverage for rideshare services and taxis, not just for healthcare transport organizations or entities, and that's helped for transportation. But sometimes that's not enough when we think about the variety of locations in which patients live, particularly in the rural settings where those ride sharing and taxi services may not even be available services. So transportation and the distance to care sites, because the distance requires time. It may also require the economic status to have fuel in the tank. Earlier in my career, when I worked with underserved populations, it was not unusual that patients would hitchhike to their appointments that were scheduled without any input from them and mailed to them. And if they were a day or two late, they would sometimes be turned away by the organization, by the practitioner, for having missed their appointment, instead of recognizing the environment in which they're trying to seek care and the limitations that they face in their day-to-day life, and our opportunity to meet them where they're at. And then lastly, I just want to comment on stigma and bias as well. Healthcare puts a lot of bias in front of patients that interferes with the experience of care and can impose administrative burden when we don't recognize that an individual may have literacy challenges, not just health literacy, but ground level literacy challenges. When we prejudge individuals because of their condition or because of elements of their behaviors we identify in collecting our social history, whether it's alcohol, tobacco, or illicit drug use, sexual habits, sexual orientation, gender identity, etc. Those become barriers sometimes to being able to access care, or when care is accessed, to be able to receive care that's consistent with the care of others who don't fall into those categories that we may be biased against. And so, all of that comes together in this constellation of both opportunity,
Mhm.
as well as I think what represents a stacked deck against many patients that we really need to be redesigning healthcare systems for. We can redesign it in reducing some of those administrative burdens that are imposed by the system design. We can also do it by addressing some of the inherent factors that our patients are contending with, and trying to reduce those barriers to provide for a better experience and better access to care. Thank you.
Wow, that was a lot. I think I don't know how Dante feels, but that.
Oh, well, thank you. And I think it's really important that you really did highlight quite a few of the things that are in the CMS framework. So our agency looks like we're going in the right direction. And so it's good to hear that we are. That was, yeah. Yes, it was definitely. But I want to pivot toward Dante. You're in the situation of having experience with the healthcare system as a patient, which we've heard from the doc side, but you also experienced it through your work helping others as a patient navigator and advocate. Often patients, particularly those with complex medical conditions, as he just explained, can be left to coordinate their own care, which can be a challenge, and as he just noted, a barrier. What are some of the burdens and challenges that you see most pressing to people that you work with? And what's one idea you'd like to share with clinicians that can help patients acclimate themselves to the care setting?
Patients are experiencing these kind of like systemic disempowerment issues that can be particularly frustrating and are a part of like institutional biases. These issues like non-integrated workflows, clinics that are non-intuitively designed or in inaccessible places, heavily burdened staff that really lack the training in things like active listening, communication skills, empathy, trauma-informed care, things that people really want from their clinicians and providers, but really aren't included in the training of staff. Tech concerns are an often mislooked part. The fact that most organizational websites are just poorly designed or not optimized for mobile users. They don't allow for users to even do things like upload eligibility documents, the long wait times for appointments and communication, this reliance on paper instead of using technology and phone calls, and also just time poverty in general. The fact that appointments now are generally shorter, 15 minutes. We are asking for folks with chronic conditions to manage 3 months of their life in a 15-minute visit. I think that one of the ways that providers are adapting towards this, and one of the things that I've been encouraged by, specifically seeing in the FQHC or Federally Qualified Health System model, is the rise of more co-visits. So providers realizing that 15-minute appointment is a perfect time to bring in a nutritionist, a pharmacist, a community health worker, or a patient navigator to work with that patient to help them achieve their goals, to help them understand their diagnosis, help them maintain adherence. I think that is an exciting opportunity. And I think likewise, the kind of like move towards streamlining eligibility in certain ways, like the use of biometrics, for example, for check-ins, allowing for folks to do update history, prescription changes through their portal before their visits. These take out moments out of appointments that get eaten away in those 15 minutes that are saved because patients are able to just push their use their fingerprint as proof of their identification compared to having to have that checked by an eligibility person through charting system. So I think that providers are adapting in some interesting ways.
Those all sound like great ideas. I'm sure somewhere in the health system they've started some of those, some of that, but I don't think anyone is using a fingerprint yet. I will attest to that. So, Dr. Tootle, you have been a surgeon for over 30 years. I hope you don't mind us sharing that.
That's
And I
okay.
know that healthcare equity has been one of the great importance to you during that time. So, based on your experience, would you share your thoughts about some of the challenges that we may not be aware of that may exist between the time of diagnosis and treatment, and how disparities may emerge, the complexities involved in communicating the disease and the illness specifics, including the constant and unfortunate shortage of staff and time and the reality of those statistics. Could you help us with that?
Well, I can give you my experience having been the chair and the chief of surgery in a rural health system. East Carolina or ECU Health now, is compromised of an anchor medical center of 1,000 beds in a 29 county region that has 10 of the poorest counties in the United States. It services, I think, now 8 critical access hospitals, and we run a fleet of helicopters, depending on the hurricane season, whether we have 5 or 6 or 8 if the roads have washed out. I think that there's a lot to this in that we recently did a study several years ago now, where we looked at the diagnosis of acute cholecystitis and surgical complications, and those who have access to health care, and by that I mean insurance, can have their gallbladder removed pretty quickly. If you were self-pay or have other confounding factors in the rural setting, obesity, poor social determinants of health, poor healthcare literacy, or literacy in general. We had a high illiteracy rate in the region of about 30%. Your risk of complications post-operatively goes up tremendously because there's a delay in your surgery. You're also seen in emergency departments more frequently because you don't have that access to follow-up or the resources to get to that follow-up. So it's a multifactorial problem. It's not only social determinants of health, it's cultural issues of trusting a medical establishment that is often seen as, I don't want to use the word profiteering, but is all about the money to get you health care. It also has to do with communication styles and some of the things that other folks have talked about on this panel, active listening, sensitivity to not being able to get a car ride to your appointment, or practitioners who in the region are allowed not to take Medicaid patients, for example. And so, I think that also access to surgeons. We had multiple hospitals that when the surgeon went on vacation, there was no surgical access for those patients, hence the helicopter. And that creates a tremendous burden in the health system to pay for air transport when all you need is a doctor in the rural setting. We're 30,000 surgeons short, probably more now, and we're geographically maldistributed. No one wants to live in a community where they're always on call. And so I think we have to look at a lot of different factors. One is a structure where there is not just equity, but also equality, where we all see patients as patients and not as revenue opportunities. I think we also have to think about how we train physicians. How do we create incentives for those, even generalists, general surgeons, family medicine practitioners, gynecologists, obstetricians, and there are going to be obstetrician deserts in rural parts of the United States, and having had children and been in labor, that would not sit well with me. I think we have to address this as a holistic issue. I think there's so many parts of this, and I think Dr. Salvin Harmon actually really put it together very well. Access to care, we have to have I think we need to really look closely at how we educate doctors and doctors of osteopathy. How do we streamline and make graduate medical education more affordable, especially for diverse populations of students? Because if you want to have someone who's culturally sensitive to someone's cultural and religion, you have to train those practitioners to make people trust the system better. Oh, look, there's me. So again, I think there are lots of opportunities here to improve access and equity. And I'll leave it to that for discussion. That's just a few things.
Those were all very good things. I wanted to go back to Dr. Salvon Harmon for just a real quick definition. Could you give me a little bit on when you hear the terms and when we use the terminology patient safety, what are we saying?
Absolutely. So, one definition from one of the modern founders of the safety movement, who came from outside healthcare, but it's often cited and invoked in healthcare, James Reason, said safety is not the freedom from danger and risks. It's the ability of individuals and organizations to deal with risks and hazards so as to avoid damage or losses and yet still achieve their goals. And I think behind the scenes in healthcare, that probably resonates within the business model of healthcare. But I think we have to acknowledge that patients have a very reasonable expectation that healthcare systems will manage those risks and keep them, the patients, safe throughout episodes of care across all settings. And so we might translate that definition of patient safety as producing safe healthcare outcomes and avoiding or preventing healthcare-related harm to patients. Right? That's really what we're trying to achieve, is to heal and not harm. And so I think we also want to be cognizant that definition of safety is not just physical safety, but the patient safety has to be understood to include emotional safety. That we have to focus on the emotional impacts of injury and disease on every patient's sense of self, which includes their autonomy, their ability to function independently, their self-image, how they view themselves as an individual, but also how they view themselves within their home, their work, their community, and similarly their functional status in those settings of home, work, and community. All of those tie into feeling like you've received emotionally safe care as well as physically safe care that didn't result in any physical harm or emotional harm.
Well, thank you. I have a question from the chat here that I'm going to ask each one of you to see if you can respond to. And we'll start with you, Dante. Who do you see as the driving force at individual institutions to start an effort to make care accessible to those who are faced with these types of barriers we've identified today?
I think that leadership comes from two places, especially in organizations, or a couple of places. On the provider level, I think that comes from CMOs, chief medical officers, saying that addressing those, making equity a framework, including it as a metric of organizational success and health. And on the other end, I would say the other kind of part of organizations, and this is a part that is often underfunded or undersupported, are patients themselves. I think that whether that is community advisory groups, patient advocates, folks in the comments and complaints departments at organization compliance or groups know for a fact that patients have a vested interest in seeing equity being integrated into the work. I think now it's it's just having organizations reflect that back to patients themselves.
Right. And I'll ask you, Dr. Tootle, would you like to respond to that one as well?
Sure. You know,
Mhm.
I would agree with Dante in that it is the patients themselves and the community groups
Mhm.
who come to the hospital and, you know, demand and advocate for access and care. I would also say in my experience in academic medical centers, it has been the younger generation of doctors and trainees, whether that's medical students or nursing trainees or physical therapists. Um, the younger generation of students really wants to see the playing field leveled for patients who need them.
That's great. Dr. Salvon Harmon, did you want to speak to that briefly before we go to the next question?
Certainly, thank you. I'll differ slightly from my colleagues on the panel in that I think governing boards are uniquely positioned to lead
Mm.
because they sometimes bring in perspectives that are different from what the C-suite, the leaders of a hospital team or a healthcare system team may have. So I think in combination with patient and family advisory committees or councils, and I think looking towards PFACs, patient family advisory councils, at a system level, not just at the individual facility level, so that you really have a strong patient family advisory voice to accompany the board. And the board really needs to have those community member participants who don't necessarily come from industry or from healthcare backgrounds to also be representing that voice. I think they're really well positioned. And that's not to say that I take opposition to what my colleagues have shared. But if I had to identify two, that's where I would place mine.
Great. Well, all of you have mentioned one element, at least, of social determinants of health. You've talked about transportation. You've talked about a little bit, their personal needs of patients. How important is that going to influence decisions in the healthcare field? When you look at things like literacy, I think that was even brought up. I'll start with you, Dr. Tootle, and then Dante, I'll come to you. How's that?
You know, it's interesting. The concept of whose responsibility is it to address the social determinants of health? Is it the health systems themselves? Is it the insurers? Is it the patients? And I think it's a combination of the insurers and the health system, but it's also the responsibility of all of us to work to improve education, public transportation, to come up with a system that doesn't exclude people who need us. The varying determinants for Medicare by state, they vary substantially. And so, is there an opportunity to level the playing field? Because when we talk about folks that need us, when we talk about people and patients that have issues with access, we're not talking about people who can have a computer or have a biometrics. If there's no broadband in the eastern part of North Carolina, there's no way for them to access websites. And if they can't read, that doesn't help them either. My chart doesn't help people who cannot read or doesn't have computer access. So I think technology is great, but it's not universally available to everyone. And I think that there has to be a way from a community standpoint, again, the big three, the community at large, that includes all of us, the payers and the health system, have some responsibility to help take care of the populations they serve.
From what I've seen
So Dante, I'd like to hear your thoughts on this.
From what I've seen in the federally qualified health system models in Houston and in New Orleans, is organizations have an opportunity to address these social determinants of health in really innovative ways that actually increase care coordination, right? So that's like, for example, this is social work teams that get grants to coordinate transportation for clients for visits, coordinating with care providers and care assistants, medical assistants to help patients coordinate their care. Like these, I think if anything, we are one of the lessons of kind of like of COVID that we experience in healthcare is that when times are rough, people actually get way more innovative. The ways that we have like diversified delivery models for healthcare since COVID, whether that's like the rise of more home visits and telehealth options to self-management for things like OB care, like we are more equipped now than ever, I would say, to like be innovative in addressing these social determinants of health and using cost-effective technologies. But they really are about, it really comes from like an embracing of imagination that I think that organizations have to be willing to like undergo, and saying like these kind of old administrative models are not useful and a waste of time, and actually increase things like provider and staff burnout and lack of patient adherence.
So, Dr. Harmon, I have another question for you. Do you, when you think of patients, what are some resources for social determinants of health that you're aware of that you could share? You mentioned something about transportation. Were there any others you want to expound on that you're familiar with that are being addressed by the healthcare system right now?
Certainly. I think without going into specific brand endorsements, we've seen over the last 5 years the increasing presence of software that's connecting into electronic medical records that supports the screening for social determinants of health that may be adversely impacting access to care and quality of care. That not only screens, but then also provides locally directed referrals to support services. And I think that's an enormous leap forward by being able to conduct that screening in the privacy of an examination room. It's not out in the waiting area. It's not made public. To be able to print out or direct patients to resources, but again, needing to factor in their health literacy, their general literacy, culture and language, in terms of how useful that information is in the format it's being provided. But up until that was available, it was really much more difficult to get those types of screenings completed within healthcare offices, within hospitals. And they provide really meaningful connections to community services that many times the practitioners themselves and their staff didn't have awareness of. It might be that previous to that, they'd have been referred to social services, which carries with it, its fair share of stigma. And so being able to conduct that screening and have those local connections to services that could be available and contact information, phone numbers, as well as web links, so that the patients can connect based on what their ability to connect is, I think are real game changers. And so looking for those types of software products that can be plugged into whatever EMR a practitioner's office or hospital or system is using are real enablers of addressing and beginning to make a difference in social determinants that relate to equity of experience and access.
Okay, thank you so
Can I
much.
jump in here?
Yes, you can. Go right ahead.
So one of the things that I've seen a lot, especially in community health settings, is systems attempting to address food insecurity through a wide variety of means, whether that's partnering with food pantries, creating food RX programs where patients are given access to food like they are prescriptions, particularly, and those kind of things like cooking classes and nutrition classes. I think that like organizations are getting more equipped at understanding that they have a responsibility to address food instability and food inequity, and that they can do it and fit it into their models, and that it's not especially difficult, but requires some collaboration. So I think that's kind of like key with particularly addressing something like food security. It requires folks to partner with organizations that, which, if we're honest, these are often the same clients who are using these services. So if anything, we are just making folks' lives a little bit more integrated.
So that brings me to another question. This one is coming from the chat, and it's very, very relatable in the sense it says, so who on the clinical team do you think is the right person to address SDOH in the office or a hospital setting? And how do you close the loop to assure that people follow up in the community-based services? It kind of leads right between your two responses, but I'm going to take that to Dr. Tootle first and see what her response would be.
Well, thank you for that. It is the case manager or the social worker or the social work team to help make sure that the patients have what they need when they go home to be successful. And in fact, it's all of ours on the team. I would say we depend on the coordinators and the case managers to make sure that the patients have the access to things that they need when they go home to be successful and hopefully to stay out of the hospital and not come back. The issue of follow-up is a good one. Most cancer centers and some of the HIV programs that are supported by Ryan White have the resources to be able to have personnel to call and to make sure that the patients are going to come back and that the clinics are available to them. But those resources are not universally available. I think specifically about trauma services or the traumatically injured who are not chronically ill, but have a great proportion of them have poor social determinants of health. And some of those community-based resources are not available to all. They are to some, but not to all. And that's a big challenge. We don't have a consistent infrastructure at the time of discharge to make sure that people are followed up appropriately in the post-operative setting or the post-discharge setting. I would defer to Dante and to Dr. Salvin Harmon.
Yeah, I mean, I think some of it is organizational, again, imaginative limitations. Text services and text interventions have been shown to be successful and require very little management from actual staff, organization, even text reminders about like patient like provider recommendations. Those have been shown to like have some success. It's I think unfortunately, because we want to shift the buck or pass the buck when it comes to who addresses these social deterrents of health, we forget about these opportunities. We lose these opportunities instead of saying, all right, it sticks with all of us, actually. And so we all have a vested interest in creating systems that can address them.
And I would add that I think this is one of the areas that is most
Dr.
ripe.
Salvin Harmon, did you want to respond or?
Sure. I think this is one of the areas that's most ripe as an opportunity, which is the loop closure. We've done a good job moving forward with screening and with connecting to services. So the final frontier in that regard is how we bring that information back into the referral source to the practice. And I love what Dante suggests, right? We can use very low tech and grassroots types of approaches. It doesn't have to be a formal referral through the EMR with electronic connectivity to get a feedback loop going. Potentially with patients providing a cell phone number when they sign in for their appointment, and reassuring them with trust that it's actually being used. It's not just useless information being provided. When they're connected to services, they could be sent a text message to that phone number indicating that we'd like to hear back with a simple like one-word response, complete or done, once you go to that service. And you could actually track a completion rate then on those types of connections. But you could go further than that too. If you want to go bigger, you can think about not just the medical home, but the medical neighborhood. And if we can bring some of those connected services through our social determinant screening into our medical neighborhood, such that they would have more linkage, more connectivity to be able to reply to a referring practitioner's office or practice or hospital that a referred patient was seen. And it can be done in a HIPAA compliant way. It can protect privacy. It doesn't necessarily have to go into the details, but just simply confirming, yes, they actually came, they were seen, We provided them service, whatever the language might be. So I think there's really a spectrum of approaches to the feedback loop opportunities, but that opportunity is really robust right now.
I just wanted to just say for providers that there's money on the table for this kind of collaborative work, that it's getting funded more by HUD and HHS. They are encouraging this, putting out grant opportunities for it. So like money is being left on the table for this kind of work. So that's it. Like as a patient advocate, I want folks to remember that like this is opportunity to be in line with making money in business, this collaborative kind of work. That it's not just addressing these issues, but it's also organizationally beneficial for pocketbooks.
So earlier we were talking about the challenges, and I think Dr. Tootle, we were talking about some of the challenges that safety concerns and patient safety, and we've talked about the definition of that. And I just wanted to circle back to you to ask, can you share some of the safety implications, such as potential for delayed care or limited awareness or limited resources for patients in all those circumstances we've kind of outlined that since we've been speaking, but can you kind of tell us what the consequences look like?
Absolutely. I think there's no better example than the incidence of renal failure in some of the southern states and along what's called the metabolic syndrome belt. A lot of those states do not have access for single who are not gainfully employed or do not have funding sources, and so those individuals will present. They will not have intervention early in their renal failure or their kidney disease path. And because they don't have access to primary care or access to early intervention for their hypertension, which is multifactorial and genetics and diet and social determinants of health, they eventually present to their emergency room with renal failure, congestive heart failure, and dialysis. And when those patients present that way, then they are immediately they're dual eligible. They're immediately available for Medicare and for Medicaid. And so the delay and lack of intervention when the hypertension could prevent medical management of their hypertension could prevent renal failure. I think that's a pretty fair example of what happens when you can't get access to a doctor when you have hypertension as a young person. That's sort of the thing that obesity and diabetes.
Well, thank you for that. We're having some technical issues, as you're all very aware, and what I would like to say is this has been such a robust discussion about social determinants of health, inequities, ways in which we can all work together. I like what you said, Dante, about making sure we're all aware of what HHS and other agencies are doing, and then letting the clinicians know and other institutions know that there's money out there, to collaborate and do things and get things moving. I appreciate the insights and the different approach to the definition of equity and patient safety as well. So thank you all so very much. Thank you for being patient as we work through the technical difficulties. And I will reach out to Pamela and thank her as well. So I found this so helpful. I was looking at the chat. I'm getting text messages. People really enjoyed this session. Thank you. Yes, thank you so much for being so open, so frank, and so well in tune with your area of influence and impact. We really appreciate it. So what we're going to do now is take a 10-minute break, and we're going to return with a session on connecting patients and care providers across the healthcare enterprise.
Nice to meet you both.
Nice to meet you all.
Thank you all.
Nice meeting you.
Take care.